started out, I trained in McGill University and I worked as an emergency room doctor. I myself was an overweight emergency room doctor. I did family practice and eventually got into obesity medicine and overweight medicine, and started a chain of centers, became a medical director of multiple centers, and have had a lot of success in treating obesity. And I believe that right now I'm one of the physicians who are leading the country in obesity medicine, and I'm considered a leader in that field. That's really been ignored by the medical community for the last 20 years. The 5 biggest killers of Americans today, 4 of them are related directly to obesity: diabetes, hypertension, heart disease, and stroke. The only one that's known is smoking. And we deal with those 4 diseases and obesity, plus a bunch of other family medicine issues and general practice issues. And we try to reduce the risk, improve the health of our patients by getting them to get better control of their disease. And we treat obesity just like a chronic disease model, the way you would treat diabetes, hypertension, or any other disease, looking at it on a long-term basis, not on a short-term, 20-pound weight loss. We're looking at it on a long-term. How do we improve the chance of this patient surviving, having a better life, losing weight, and feeling healthier? And we've set up systems around that. The RM3A gives me a lot of information, which is what I like about it. Out of the 7 graphs that are in there, the information that I get is based, one of them is excellent, tells me about patients' anxiety level. That's the first graph. That's the way that I interpret it. And many doctors can look at it in different ways. It also gives me about the neurological, any neuropathy that they may have, cardiac variability, risk of sudden cardiac death in the future, the chance of having diabetes, hemoglobin A1C assessment, as well as parasympathetic-sympathetic balance, which is very important for us to know when we're dealing with a patient. And it gives you a bunch of other graphs at the end that assess total risk. And when you take the information collectively, as well as you chop it off by pieces, you can use that information in order to change clinical outcomes, change clinical treatments of the patient. And number one, that I use the tool is to motivate the patient to follow some of the clinical guidelines that you've already set for them, be them being having better control of their diet, having better control of the glucose, controlling their hypertension. So by doing that, we can really get the patient to understand how their disease impacts their body. So for example, when I discuss the patient about nerve damage due to diabetes, I explain to them that not only are they getting nerve damage in the peripheral body, but they also are damaging the nerves inside the heart, the nerves that conduct electricity inside the heart and tell the heart how to beat. And I tell them, and we can see that those nerves are damaged based on the test, because one of the graphs does that on the RM3A. So there's another machine that does that. When you do endothelial dysfunction, you can talk about endothelial dysfunction to the patient. Right there, the test shows you whether the patient has it. The only other way to do that is with very invasive testing that is very expensive. We've been using it for about 5 months. Since I've used it, I believe that this machine is really a mainstay and a main tool I'm going to use in my patients' assessments. I'm using it more and more often. My patients are benefiting from it more and more. It has changed my clinical decision-making on multiple patients. Patients that I would have never sent for cardiac stress test, I have. Patients who were not motivated, I was able to motivate them by showing them the results of the test. Patients who suffered from a lot of anxiety and I was able to talk to and get them to start relaxing, as well as picking up a lot of more neuropathy at a much earlier stage than I did before. And when you look at the graphs with the patient and you show them the results, be them normal or abnormal, you're conveying the patient a very deep understanding of their health, which they appreciate. The biggest challenge, I think, is getting patients and doctors to prescribe it and to use it. Once they begin to use it, then you get a very high success rate. What I did in my center is when I got the machine and we were doing the training, I had everybody, all my employees get tested on it. First, in order to assess the risk, and also for them to understand what the test does and how to interpret it. And once we did that, everybody bought into it, and now it's being prescribed more often. When a patient comes into our office and they meet the criteria that will allow us to do the test, then we prescribe the test. The patient has the test generally on another day when we are not as busy at the office. So, for example, on Wednesdays, we do a lot of tests. On Tuesdays, we do less. Once the patient has the test then gets filed just like any other lab result into the file. It gets interpreted by me, and then we call the patient back for a face-to-face meeting to go over the results and then make any changes in their therapy in order to get them healthier and better. What we find during the consultation with the patient when we give them the results is we're able to motivate them all to get better control of their diseases, be it diabetes, hypertension, of cardiac disease. We're able to get better control of the disease. So somebody who may have a very good hemoglobin A1C or borderline hemoglobin A1C, but is beginning to show some neuropathy, then at that point we can tell the patient, look, not only is your hemoglobin A1C borderline, but now you're starting to show neuropathy. That is very, very motivating to the patient and enables us to get the patient to be more rigid, to come in more often, and to treat the disease with more seriousness. For the insurance, the criteria is the patient must have diabetes, hypertension, presyncope, and we use that criteria. And most of my patients are, 50% of them are diabetic or pre-diabetic. A lot of them are hypertensive. So that covers about 50% of my patients in my practice. But we also screen a lot of the patients who either don't have insurance, have a very high deductible, and they pay cash for the visit. We've also implemented a corporate program where we send them out to a corporation and we screen people for free in order to assess them and then get them to hopefully join our practice and join our program. Based on the results, we either reconfirm that we've been going in the right direction and the treatment that we prescribed is correct, or it makes us reassess the treatment and change it. And I've changed the treatment and ordered other tests for patients and gotten a lot more aggressive with patients and ultimately motivate the patients to get a better result at the end of the day. Once you get to know it, it's actually a very simple report. There is a summary page in the front, which is the main page you should look at, and then there's a whole bunch of backup information in the back that you look up based on the summary page. The summary page gives you a very good idea of what the rest of the report looks like. So I look at the summary page, I usually spend about 2 to 3 minutes, and that's the page that I review with the patient. I just review the summary page. The other pages are for me in order to record data and to, if we do the assessment again, then we can see where those numbers have changed. So I find the report to be concise and easy to read once you understand how it works. The report makes suggestions based on the different abnormal testing the patient has. So the report groups the patient into an area that's green, which means normal, yellow, which means borderline, and orange, which means abnormal. And then based on yellows and orange, then you can assess the patient closer and see which part of the therapy do you want to change. I can tell you clearly that a bunch of my patients who came in, who were in their 40s, who were overweight, showed a marked decrease in intracardiac variability, which increases the risk of sudden death. Those patients I would have not sent for a thallium stress test, and I have. One of them came back with a blockage that needed to be stented, and I think he's going to get stented in the next little while. This gentleman had normal cholesterols and really should be treated more aggressive. He's had a borderline diabetes now for the last 4 years and really didn't take it seriously, and only now is he taking it seriously. I've also been able to be a lot more aggressive with my diabetic patients to explain to them that they are getting nerve damage. Just the fact that their sugars are high, the nerve damage is not 20 years in the future, it's happening now. So I've been able to control disease better With hypertensive, I've been able to a bunch of times rule out a little bit of white coat syndrome with it, just by having them assessed on the machine on a day that I wasn't there, and lo and behold, the blood pressure was normal, when the blood pressure was abnormal continuously for the last 3 weeks when the patient was coming into my office as she was going through a very stressful period. So I've had a lot of success just in a short period of time that I've been using the machine and getting my patients to improve their health. We have not had any issues with billing for the codes so far as I know. So we've had a smooth ride with the billing codes. We have not had any insurance deny the claims. Some of the insurance have sent it to secondary insurance, and then we had to wait for the secondary insurance to pay. But I do not know of any cases that we've had the insurance deny the payment. If your practice sees patients who have these conditions, and I think any family doctor, any internist, any cardiologist has this type of practice will benefit from this machine because this machine covers so many different diseases and it's so beneficial that I think that a vast majority of doctors will see much better patient outcomes, an increase in the revenue stream, and it's a very easy machine to use that is not complicated to get started in an office.